So this is not a what's new talk. This is about basic myositis medications. So if you're looking for the latest and the greatest, that's not what I'm covering today. Okay. That would be next door, yeah. In the rowdy group. Okay. This is meant to be a, huh?
Have you started?
Yeah, we're about to start. Yeah.
Then I'll shut up.
Okay. So yeah, this is really more basic stuff about medications that you might be on, you might have tried, you might have heard about. These are the most general medications. I'm not going to go over some of the less well-known medications, just to kind of give, this is meant to be sort of one of these 101 type talks. Okay. So I'm going to ask a little survey of the patients in the room, perhaps by a show of hands. Okay, what category you might fall into and why you might be here. Okay, so these are 3 different categories. I'm well controlled on meds, but I'm wondering if I'm on the right ones, and that's why I'm here. I want to learn about other meds. I want to learn about meds in general. You might be in that category. I am better now that I am on treatment, but I still have symptoms, and I'm wondering what I can do to get myself better. Or the third category is I am on treatment or I'm not on treatment because the treatments I've tried have not helped. Okay. So how many people are in the first category? 2 people. 3? No, 2. 2. 3? 3. Okay. 4. All right. Okay. What about the second category? Okay. So incomplete response, I might call it. And 1, 2, 3, 4, 5, 6, 7, 8, 9, maybe 9. Okay. All right. And how many people would call themselves in the third category? Like they don't think that the drugs are working really at all? 3, 4? Okay. All right. So that's
Just the
last 2. What are the last 2? Somewhere between number 2 and number 3.
That's right.
Yeah. Okay. All right. So let me start by making a few statements. Okay. First of all, I want you guys to know your disease. I want you to be your own advocate. Okay. I want you to learn as much as you can, and I think the fact that you're attending this meeting is already an indication you're in one of those. You're one of those people who are trying to be your own advocate. But that's, you want to ask all the right questions. Am I on the right drugs? I think it's wonderful that people have good doctors and they trust their doctors. But I think it's always good if you're asking the questions so that you can be the best patient you can be, even if you have one of the best doctors that's out there. Okay, because sometimes even really good doctors aren't asking all the right questions of their patients. Things are busy. Oh, I didn't realize you had that. Oh, well, you should have mentioned that to me earlier. That kind of stuff. Oh, you never brought that up. You never asked me that question before. Okay, so these are good things to really be aware of, to think about. Know your disease. Find out what you can do to be a participant in your care. So you need to know your disease to be sure that you have the right diagnosis and to make sure you're being treated appropriately. So you might have dermatomyositis, and dermatomyositis means you could have a rash or you could not have a rash. You might have pulmonary disease, which is now being more and more discussed. You might have something that we now call a necrotizing myopathy, which sounds horrible, the name, but it's actually something that we do have adequate treatments for. Some people have been told that you have polymyositis. And that's where things get a little bit tricky. How many people have been told you have polymyositis? 1, 2, 3, 4, 5. Okay. Is there anybody in the room who was told that they have polymyositis, but that has now changed? Okay. All right. And 1, 2, 3, 4, 5. Among the 5 of you, are any of you feeling like you're not responding to drugs?
Sort of. I feel that maybe I'm I'm not on the right drugs, or maybe I need to be off of them. I've never tried like IVIG or anything because nobody ever recommended it. I still have muscle weakness in my legs, so I'm not sure if I'm really on the right course or not. And I think I'd like to get a second opinion.
Okay. Anybody else feel like not responding to drugs? Who's been told that you have polymyositis?
Kind of.
Kind of?
Actually, I was told I had idiopathic inflammatory myopathy, but for the sake of the conference, I've had polymyositis.
Okay.
Because I wanted to know what to go to.
Right. So idiopathic inflammatory myopathy is basically any one of the diseases. Okay. Everything here. If you've been told that, that means you have myositis. Okay. But it doesn't tell you which one you have. Yeah. Okay. And then there's inclusion body myositis. Okay. Anybody here who have inclusion body myositis or have been told you have that? Yes. Okay. All right. So this is where the controversy is. We don't know what polymyositis is. Okay. Polymyositis is an old diagnosis. It's a diagnosis that was created back in 1975. These two guys who were from this institution called UCLA, which happens to be where I'm from, wrote this paper in 1975, and their names were called Dr. Bowen and Dr. Peter. Okay, so doctors who diagnose myositis all know about Bowen and Peter's papers. There were two papers in 1975. And the only two myositises that they talked about in their paper was polymyositis and dermatomyositis. If you have inflammation in your muscles and you don't have a rash, you have polymyositis. If you have inflammation in your muscles and you do have a rash, then you have dermatomyositis. That was for the most part, that's what they said. Okay. All right. So in other words, if you didn't have a rash, you have polymyositis. Okay. Well, back then we didn't know about these other diseases. We didn't know about necrotizing myopathy, which has pretty much been described by Dr. Mammon, who's on our medical advisory board. Okay. He's done a lot of the work to establish that. And then inclusion body myositis was really not a diagnosis we knew about until probably about 10 years after that, in the 1980s. So you see, the problem is that back in 1975, if you had a rash, you had dermatomyositis. If you didn't have a rash, you might still have dermatomyositis nowadays, but back then we would have said you had polymyositis. If you had inclusion body myositis, we would have called it polymyositis. If you have necrotizing myopathy, we probably would have called it polymyositis. Okay? So things are kind of changing, and at this point, there are other things, and there's also something called antisynthetase. Okay? Anybody been told they have antisynthetase? So now we start breaking things off. And so, you know, if you were to use only these four categories, antisynthetase would probably sit in polymyositis. But nowadays people are carving off antisynthetase as their own thing, and it's not clear if there's going to be anything left in polymyositis. Okay? But it's just a bunch of names. It's like, what bucket are you going to put it into? Where are we putting our patients into, category-wise? But you need to know your diagnosis, but if you've been told you have polymyositis, you also need to know the controversy, okay? Because it could affect how you get reclassified, okay? Be your own advocate. So, is your CK elevated still, now that you're on treatment? Or has it come down? Have you responded? Have you been checked for all the different myositis antibodies? Nowadays, we think these antibodies are important. I will tell you, 10 years ago, we did not think antibodies were important. Okay? Things keep changing. This is the update. All right? I believe that everybody who's been told they have myositis, who's been diagnosed with myositis, needs to have their antibodies checked. Okay? All the different antibodies that are possible. Okay? It's not a perfect test, but if something comes back positive, it could be very meaningful. It could actually really clarify what you have. Why am I going through all this? Because it matters. If you start talking about treatment, sometimes certain diseases have respond to certain treatments better than others. Do you have lung disease? Have you been checked for lung disease? Okay. Certainly, if you don't have antibodies checked, you should definitely ask questions like, are you short of breath and never been checked for lung disease? Usually we get a CAT scan of your chest. Sometimes we have you breathe into this tube and see how well you can breathe. Okay. There are certain diseases which usually are not associated with lung disease. There are other diseases which are known to be strongly associated with lung disease. And this is why one of our medical advisory board members now is a pulmonologist. It's really important that we understand lungs, okay, in myositis. Because the inflammation can go to muscle, it can go to skin, it can go to the lungs, it can go to other things too. Okay. And that's FVC is what we call the forced vital capacity. So if you do have lung disease, your doctor probably should be looking at that number, which is the number that comes off of that test when you breathe into that tube. Okay. And if you've had a muscle biopsy, what did it show? That might be helpful. I mean, that's a little bit more sophisticated, but you can discuss that with your doctor. So the myositis antibodies, they're these synthetase antibodies. There's the anti-synthetase syndrome. These are the most common ones. There are other ones as well. There are the necrotizing myopathies, and there are specific antibodies for them as well, SRP and HMG-CoA reductase. There are the dermatomyositis antibodies, and you don't have to have one of these antibodies if you have dermatomyositis, but some of these are pretty useful things to know. Like, for instance, a couple of these are strongly associated with cancer, and so if we see those antibodies, then we tend to be very vigilant about screening for cancer. A couple of these tend to be associated with lung disease. MDA5 can also be associated with lung disease as well. And then if you've been told you have inclusion body myositis, or if it's not clear what kind of polymyositis you have you been screened for inclusion body myositis? There's actually an antibody for that too. And unfortunately, it's not all that easy to order all the different tests. I would have to check 3 different boxes, I think, in the form that I would send you to the lab with. 3 separate boxes to test for all these antibodies. There's one box that would cover these. There's another box, one box that would cover these plus this, another box that would cover this one, another one that would get this one. And so if your doctor is not very used to diagnosing myositis, it may not be all that clear to him or her how to order these tests. Yes?
If you test negative for one of those antibodies, is that a clear answer?
Usually, yes. It's a clear answer for that antibody. But you want to be tested for all the different antibodies. And there probably are other antibodies that we haven't discovered too, but these are the ones we know about. There are actually a few more that I didn't put on this list, but these are most of the antibodies that we know about in 2019.
But you could still have, say, dermatomyositis and not be positive for any of those antibodies.
You can have dermatomyositis and not have any of these antibodies. That is correct. That is correct.
Is that common or is that rare?
I would say it's not uncommon. Yeah,
not
it's
uncommon.
pretty. It's reasonably common. Yeah. Mm-hmm. Yeah.
If you test negative for antibodies, is it possible to later on test positive for the same ones?
I don't think I've heard of that happening,
Okay.
but it's always possible. Because honestly, we aren't rechecking people all the time.
You aren't.
We are not. And the other thing is that most of these antibodies have only been available in the last few years. Okay. Some of these antibodies, like Jo-1 has been around for a couple of decades. MI2 has been around for a couple of decades. And the other ones here have all been discovered in the last 5 or 10 years.
Okay.
Yeah.
How stable are the numbers for those? I've had 2 tests, and my NXP2 was, I don't know what unit it is, but the first was 35, and then it was 22 or something.
It could fluctuate.
It can
Yeah.
fluctuate.
Yeah.
Oh, okay.
It could fluctuate.
Will it fluctuate as a function of treatment? Or just
Yes, it could, yeah. So if you do test positive for one of these antibodies, it's very likely that that is an indication of what disease you have.
What happens if you have 2 from 2 different families?
Well, that's a little more unusual. You probably would be more likely to have one of those syndromes, but that would be interesting. I don't know if I've personally seen that before.
Sure, I'll show you my results. I just little elevated of Joe 1, but major of NXP2.
Then I would say you have an XB2, yeah. Do you have a rash?
No.
Okay. Yeah.
These are myositis-specific antibodies. Will you also be showing myositis-associated antibodies? Because I'm Q antibody.
Yeah, so myositis, so Ku antibody, yeah. Were you the one who asked that question in the audience?
Yeah.
Okay, yeah. I mean, that's one of the rare antibodies. I mean, I think that's something that most of us have a lot less experience with. Even, Olivier, who's written a paper about Ku, he didn't really dare to say too much. And so he's probably one of the more significant experts in that syndrome, and I think it's hard to say something if you're not sure. No.
But could I read about it somewhere online in English?
You can.
Not French.
No, I think his papers should be in English. Yeah, it should be in English. The international language of science and medicine is English.
Okay.
Yeah.
So far.
Yes. Yes.
So if you were diagnosed, say, more than 10 years ago and you never had been tested for antibodies,
I would go to your doctor and ask for these tests to be done, yes. And if they don't know how, then ask them to find somebody who does know how. Yes.
Sir,
And even if you're adequately on treatment, even if you feel like you're on treatment, you're doing well, and the medications are working, I would still ask for these antibodies to be tested, because now we have a better understanding about these diseases now. Yeah. Let me just point out.
On the DM antibodies, which one is the cancer one to watch out for?
This one's very significantly associated with cancer, and yes, TIF1 gamma.
TIF, okay,
And NXP2 can also be associated with cancer, but TIF1 gamma very strongly associated with cancer.
okay, thank you.
Yeah.
there is a lab in Oklahoma.
Yes.
So how do you contact them and how do you send them bloods through our doctor? You have to do that?
Yes. So the doctor, it's the Oklahoma Medical Research Foundation. Okay, and it is considered by most U.S. Myositis doctors to be the most reliable lab. Okay, it's got its own problems though. It's very slow. Okay, so usually when I send off a test, I get the result 3 months later. So if I want to know a little bit faster, I will send to one of the other laboratories.
Is it slow because they're careful, or is it slow because they don't have enough people, or?
I don't know.
They're just slow.
I just know that they're slow, but they have the reputation for being the most specific. Yeah, but they also do not test for all these antibodies. So they test for everything here except inclusion body myositis and HMG. But everything else is they can test for.
What's the name again? Oklahoma?
Oklahoma Medical Research Foundation.
Is that panel real expensive? I mean, is it really?
It's it's a few $100s. It's not more than it's not more than 1,000. Yeah. Yeah. I wasn't sure if that's expensive or not, so I wasn't sure how to answer that.
12,000,
Yeah.
2,000.
I send genetic testing, and that can be very expensive sometimes. So, any other questions? Yeah. So we now really believe in people getting their antibodies tested. We didn't used to say that. I didn't used to say that. I say that now very strongly. Okay. Yes.
How often should you have them repeated?
I don't think you need to have them repeated. But I mean, somebody did ask the question, well, if it's negative, should I have it done again to see if one of them becomes positive? I don't know the answer to that. I don't think we know if people can convert to positive. Yeah.
I always ask this question about Rituxan. Should I wait till my Rituxan runs out to be tested? I mean, should I wait past my 6 months to be tested?
Oh, I see. At the end of, yeah, you can have it. You can wait. I have found in other diseases where antibodies are part of it, part of the disease, that the antibodies don't disappear, even with Rituxan.
Even with Rituxan?
Yeah. Even after they've been treated with Rituxan, the antibodies usually do not disappear.
Oh, okay.
Yeah.
That's reassuring.
Yeah. But yeah, if you want to make sure you do it at the best time, maybe you want to wait right before you get Rituxan the next cycle. Yeah.
So if someone like myself has polymyositis, I should have this done, and it's probably going to indicate me falling under one of these categories.
Yeah, I mean, I think at this point, I don't know how many. There are many of us who are not sure that polymyositis should still be a category. Okay. We think that polymyositis patients will probably get recategorized into one of these categories. But just because you don't have an antibody doesn't mean it's not in one of these categories. Like, I have seen necrotizing myopathy patients who do not have these antibodies, but then they do have necrotizing changes on muscle biopsy. But we would used to have called that polymyositis. Yeah. So I'm not ready to completely get rid of the polymyositis label, but I think that people are starting to move in that direction.
Well, what if you have lupus with polymyositis? And
That's a little bit different. That probably will be a little bit less strict on that, because I might still call it polymyositis because it's a little more complicated of a story. But if you have one of these antibodies, then I would put you into that category. Yeah. You have a question.
Yeah, I was tested 10 years ago when I was first diagnosed. Came up antisynthetase with Jo-1, but the doctor at Stanford at the time said looked like it was something slightly different that he hadn't seen before, but it would probably be treated the same. But I've always been categorized as Jo-1. Do you think I should have it retested and see if somebody's come up with what it is?
If you test positive for Jo-1, I would believe you are a Jo-1 antisynthetase patient. Yeah. I'm not quite sure what the controversy would be. Was there another question here?
Yeah. I was positive for SRB.
Yes.
And then next year I tested it again and I became negative. So which report?
Were you treated?
Pardon?
Were you treated?
Yeah.
Did you receive treatment in the meantime?
Yes.
Okay. Yeah, you probably have SRP antibody myositis.
So what it became negative? It was
Sometimes
positive.
treatment could do that, yes. No. It doesn't always, but yes, it could make your antibody disappear.
I just took Prednisone. That's all I do. So it can happen.
Yeah, we've seen that happen.
For DM, if you tested and you have none of those antibodies, does that complicate or simplify treatment?
I don't think it complicates it. I think that you still have DM. Yeah. If you have a rash, then you have DM. Yeah. And if you're responding to treatment, it's more like if you have one of these antibodies that is associated with lung disease, it's associated with cancer, it makes us a little more vigilant about looking for things. So that's the story with DM. Okay? Good questions. All right. How useful is a muscle biopsy? Well, I mean, as a neurologist, we've historically been more interested in muscle biopsies. And fortunately, that's not necessarily as strong as it used to be, but sometimes we still do want to do muscle biopsies. But you want to make sure that it's in the hands of an experienced clinician. It can be a minor procedure. I do it myself, and most of my patients, I don't have a whole lot of complaints about it. You want it to be read by somebody who is experienced at reading muscle and really talks to the doctor who takes care of people with muscle disease. So sometimes that's a little hard to find. You may have to get a second opinion. We discussed this in the panel today. Like just because the pathologist says, oh, I see this, and I think this is polymyositis. I mean, I used to go to the pathologist and say, why do you say it's polymyositis? Because I don't think it is, all right? And I would have discussions with him, and now he never writes that anymore, so, you know. Yeah. But it is helpful because, you know, sometimes we see things like rim vacuoles which tell us, oh, you don't actually have, you know, polymyositis. You just have, you know, you have rim vacuoles and inflammation, which tells me that you have IBM. And, you know, right now we don't have very good treatments for IBM. And that's an important thing to know because I have seen many patients who have IBM who've been told they had polymyositis, and they got all sorts of treatments, and they just continue to deteriorate slowly, but continue to deteriorate despite being on all these treatments. Okay, and you can get side effects from these treatments, especially with prednisone, high doses of prednisone, to try to get the muscles to be stronger. And now we've learned through many, many, many clinical trials that you really shouldn't try, okay? Because it's really not worth trying the drugs that have been tried in so many patients before. So do I have something that's untreatable, like IBM? IBM is the really main, you know, thing that's not really treatable at this point, that we don't have good drugs for, okay? Are my symptoms due to something else? I've been started on treatment, but I'm still tired. You know, I've seen patients, and they will say, I'm still symptomatic. And I say, well, what are your symptoms? Well, I'm tired. What do you mean you're tired? I'm fatigued. You use that word. Well, sometimes it's, you know, you're taking too much prednisone. If you look at the side effects of prednisone, I'll list them a little bit later, it actually causes muscle loss. Go figure, okay? We're using prednisone to treat myositis, yet when we use high doses, it's going to cause muscle loss. All right, so maybe if you're experiencing muscle weakness, maybe we need to back off on the prednisone. It's not that we're under-treating you, maybe we're over-treating you, okay? That's a possibility. Right. Believe it or not, a lot of patients, especially if they've gained weight on prednisone, they develop sleep apnea. And then they start feeling, oh, I'm so fatigued all the time. Like, what do you mean by fatigue? Well, I just come home and I have to take a nap. And it's like, well, taking a nap is not a muscle disease. Okay, but then that term fatigue kind of gets mixed in there sometimes. And either the patient thinks this is part of the disease or the doctor thinks it's part of the disease, and we start upping the prednisone even more. And that's not the direction we want to go. Okay. And then we usually like to see if it's a muscle disease, we'll follow CKs. If there's lung disease, we like to follow pulmonary function tests. So I made a comment about inclusion body myositis. Just want to convince you, these are the publications and the clinical trials that have been done all on inclusion body myositis. This is the year, this is what drug was tried, this is where it was published, if it's been published, this is how many patients were studied, okay? This is how many months they put the patients on, okay? If we think somebody has inclusion body myositis, we don't use these drugs for these reasons. It's been well documented, okay, that a lot of the drugs, and a lot of the drugs that I'm talking about today, should really not be used in inclusion body myositis, if we're sure that you have that. Okay? Unfortunately, it's not uncommon to misdiagnose inclusion body myositis as polymyositis, okay, because the muscle biopsies can look kind of similar. Rim vacuoles, no rim vacuoles. If you have rim vacuoles, you have inclusion body myositis. If you don't have rim vacuoles, that doesn't mean you don't have inclusion body myositis. It just means we didn't see vacuoles. Okay. Yes?
If you've been diagnosed with DM, is it possible that it's active?
If you've been diagnosed with DM, usually that's not a diagnosis that's misdiagnosed because the rash can be classic, but yes, occasionally you can see a patient who just happened to have a rash at the time when they had some muscle disease and then turned out not to have DM, had some other muscle disease. Yes, that's always possible, but So what is my doctor using to decide how to treat? Well, if there's a rash, is there weakness? Like for instance, if somebody still has a rash, we might up the medicines. Or there are certain medications that perhaps, I'm not going to talk about these medicines, but that are more rash specific. Instead of just treating the whole disease, we might put you on medication. Sometimes like Plaquenil, for instance, helps with the rash a bit. Okay. But are we following the weakness? Are we looking at perhaps, are the muscles getting stronger? Are we looking at blood tests like CK levels? Various different things that I might ask my patients to see if the drug is working. So the visit to the doctor says, I want to put you on A, B, C, and D. And you're like, whoa, hold on a second. That sounds like a lot of different meds. Okay. And that's where things can be a little bit confusing. Like, do I need to be taking all these meds? Am I really that patient that, it sounds like you're throwing a Hail Mary on me or something like that, right? And sometimes that's not the case. Sometimes we put patients on multiple meds at the beginning, okay, and then we back off on things. And so what are these meds? What are the side effects? If you put on a lot of different meds, do I have to worry about drugs and drugs interacting with each other? And what is the plan? So there are different plans that we might have. And I'm just going to illustrate sort of the concept of different ways which you can start treating somebody. Maybe you want to say, let's do an induction, a high dose of something, and then go to a maintenance. Okay, that could be a plan. That sounds like a cancer type treatment, but you can imagine that if you're trying to treat something like this, I say myositis is a little like a burning house. Okay, your body is your muscles are your house, or your lungs and your skin is your house. Okay, it is burning, and you got to put the fire out. And after you put the fire out, doesn't mean the house is fine. Sometimes you have to rebuild it. Okay, so that response, you getting better, sometimes that induction might be about putting out that fire, and the maintenance might be making sure the fire doesn't come back. But your recovery might be a long time because you have to rebuild the house. Your muscles have to rebuild because they've been damaged, and you need to grow those muscle cells back. Okay. Sometimes doctors will say, let's start low and go slow. Sometimes they'll say treat and then wean. Try to get you off all the meds. Okay. Sometimes we say, we have drugs that work fast, we have drugs that work slow. I'm going to put you on both. Okay. And then I'm going to use the fast drugs to bridge you to the slow drugs because I like the slow drugs better, but I got to treat you now too. I can't wait until 6 months from now when the drug starts working, right? So here are some of the common meds that I'm going to be talking about today. Prednisone, I'll talk about Azathioprine, mycophenolate, Methotrexate, Rituximab, IVIG, and there are others, but I won't be talking about those. Okay. So Prednisone. Prednisone, we were having this discussion last night. It was a wonder drug when it was discovered back in 1948. In fact, it was such an incredible wonder drug that the Nobel Prize was given 2 years later, okay, for Prednisone, because it was a life changer. Okay, people went from not being able to do anything, mostly arthritis patients, to, oh my gosh, being able to do stuff. And so it was found that this is just some extract from the adrenal glands. And so these steroids were discovered, these cortisone-like steroids. It works, but it's got a lot of side effects, right? So there usually is going to be some improvement for most of our patients. It may not be dramatic, but we usually do notice some improvement for most of these diseases, except for inclusion body myositis. And we will also see that the CKs, if they're high, and not everyone has high CKs, but if they are high, they'll usually come down with treatment. So the effect is usually within days to a couple of weeks. Okay. But like I said, the effect is more about putting out the fire. If you had a really bad fire, it's going to take a while for the strength to come back. Okay. So if the disease has been going on for a while, you may not notice a benefit, but maybe the CKs will come down and you don't continue to deteriorate. You have to start waiting to turn the corner a little bit. Okay. Side effects, I think everyone's somewhat familiar with these side effects. Weight gain, bone loss, skin changes. These are mostly long-term stuff. You know, the longer you're on it, the higher the dose you're on it, the more side effects you have. You know, and as I pointed out earlier, muscle loss. You know, and like I have seen patients who've been over-treated with prednisone and they feel weak because they were over-treated with prednisone. Yeah.
Let me ask a quick question.
Mm-hmm.
If you're only on 3 milligrams of prednisone, would that be significant enough to cause any muscle loss?
3 milligrams, usually not. No, it is dose dependent, yes. Yeah. So concern, I mean, you can get infections. And of course, one of the things we worry about with prednisone is if you've been on it a long time, your adrenal glands are asleep, which means that you really should not be stopping this stuff cold turkey, okay? You will have withdrawal effects, okay? So if you're on, especially if it's 10 milligrams or more, and if you've been on it for more than a month, we usually wean very slowly, okay? So it's like landing a plane, nice and gradual, okay? And that helps because this is the hypothalamus, the pituitary. Here's the adrenal gland. That's making cortisol, right? But when you take prednisone, everything gets shut down. You need that to wake up, that whole system to wake up again.
Are there any drugs that you can take to help wake that up so that it's not such a slow wean or slow taper?
I think the safest thing to do is actually just to wean. I don't think that, I can think of some ways, but I don't know if I've ever done it before. Okay, Imuran, azathioprine. And how many people have taken this drug before? How many of you are still on it? Okay, so half of you. Okay. So it looks a lot like DNA or RNA, and it inhibits the synthesis of purines, which is basically DNA and RNA type stuff. So if you inhibit DNA, then cells can't divide. If cells can't divide, then the cells that need to divide are not going to be made very well, and immune cells like B cells and T cells are not made very well. And so that's one way how you can suppress the immune system, is sort of cut the supply of immune cells by not allowing them to divide very well. It takes a while for that effect because you kind of have to wash out all your current cells, so just because you cut the supply of B and C cells, you're not really cutting it, but you're lowering it. Just because you're lowering the B and T cells that are being made, you kind of have to wait for that whole pipeline of immune cells to kind of die off before you have a real effect. So it's going to take months. Sometimes people say even up to a year before you get a full effect. Side effects, it does suppress the bone marrow. Bone marrow is where these cells are. You want it to suppress the bone marrow, you just don't want it to suppress too much. So you just want to make sure it's not a devastating bone marrow suppression. It can cause vomiting, GI side effects. There is an increased risk of lymphoma if you take it long term at high doses. Skin cancers, I've seen that a bunch of times. Usually that's if they get skin cancers, I just stop it and try some other medication. So we usually monitor blood counts and liver tests because I've seen it affect the liver as well. This is a newer medication, not so new anymore, but it's newer than azathioprine, which has been around for 40, 50 years. Mycophenolate or Celcept or Myfortic are the brand names that you might hear about. How many people have taken that? Okay. And how many of you are still on it? A lot of you, okay. Most of you probably. So it kind of works similarly. It works a little, but just a little different enough that the side effects are a little different. Cuts the B's and T cells out, so it takes a while for it to happen, 6 months to a year. Side effects, vomiting, diarrhea, low white blood cell count, possibly increased risk of cancer. It's kind of based on our experience with azathioprine as well. And we monitor chemistries and blood count for this as well. Methotrexate. It works through multiple different ways, but it seems to also have a very similar effect on DNA and RNA synthesis. There may be other mechanisms. So kind of has that similar effect that azathioprine and mycophenolate might have. It's usually given weekly, either by injection or you can take pills. How many people are taking this or have taken it? Okay, good number of patients here. Okay. Side effects, you can get nausea, low white count, skin breakdown in the mouth. You have rare cases of cancer, lung disease, liver disease. We usually monitor chemistries and blood count.
My major side effect was extreme fatigue, and I guess his name Methotrexate fog or something.
Methotrexate fog. Huh?
Yeah, but it's just fatigue.
Mm-hmm.
For 3 or 4 days after I injected it, I hardly could do anything really. So that should be put down there.
Okay, yeah, I'll add it the next time.
Maybe for the next one.
For the next year's slide, yes.
How do you decide which you're going to treat with?
How do I decide? I'm going to be careful about. Every clinician has a different style. I mean, I think I tend to shy away from azathioprine more now because I've run into some patients who've had some side effects. I do like mycophenolate. I do use methotrexate. So those are the two medications I tend to use more for long-term treatment.
What was that one and what was the other one?
The two M's, methotrexate or mycophenolate. Those are the two I tend to use a little more. Celcept, yes. Celcept is the, or Myfortic, yeah, is mycophenolate.
I did have a question on the Myfortic, actually the other one too. It says chances of cancer. Okay.
Yeah.
They also say DM is chances of cancer in the first 3 years. I'm always asking myself, Gerald, is it the Myfortic you're taking that's a cancer risk because it makes you cancer risk, or is it the DM? The doctor said, no, it's not the medicine that causes cancer. So I don't know, that's hard, because it keeps showing up on slides, and you read about it in the world warning that the medicine can cause cancer.
Yeah.
So I don't know, I wasn't sure what you've seen.
I don't think we can answer that question. Okay. It's a hard question, and I think that I think that there is an increased risk of cancer. It might be pretty small. I think that most patients who have dermatomyositis and have cancer probably get it from dermatomyositis. It would probably be the patients who have TIF1 gamma, maybe some of the patients who have NXP. Yeah.
Have you had patients like, I have RA, so I've been on methotrexate for probably 12 years. Have you seen patients that, like I take the full 25 milligrams for so long? Do you know? I mean, what do you think about it? It's so long, so many years.
So yeah, I don't have too many patients who are taking 25 milligrams of methotrexate. It's on the higher end. I do have a few, and I don't have that many that have been taking it that long. So, but what was your question about that?
Well, that's just what I just was wondering what your experience is with.
Yeah, I mean, some patients do need it, and so that's why we prescribe it that way.
So what's a good dose?
What's a good dose of methotrexate?
The one that
I mean, I've seen doses, 15 milligrams is a fairly typical dose that I use. 15, one time. Yeah. But if you're a little heavier, then sometimes we might aim a little bit higher. It really kind of depends. If we're not feeling like the drug is working well enough, we might take it up, regardless of what your weight is.
I'm asking because my doctor's going to put me on that next month.
Okay. Yes, question back there.
I don't see Orexia on your list of drugs.
Yeah, it's not one of the ones I'm talking about.
Yeah, should
How
someone
is
be
your
on
drug is
Orexia?
working? By CK or muscle strength, muscle weakness, all of the above?
All of the above. And it depends on your clinician, it depends on your doctor. Their neurologists are going to tend to focus a little bit more on the muscle stuff. You know, if you might see a pulmonologist. I do pay attention to the lungs, but then, if you have antisynthetase, that's something that, we're encouraging doctors to pay more attention to, for instance, in the pulmonary function. Okay, IVIG. So these are different kinds of IGs. IgG, IgE, IgA, IgM, IgD. And really, IgM and IgG are some of the most prominent parts of this antibody immune system. Okay? And IgG in particular is what is in IVIG. It's a lot of G's in there, but so when we say IVIG, it's it is a blood product that's taken from healthy donors, and what's being done is that it's being purified for the IG, which is most of the IG. It's being purified for IgG, which is most of the IG that's in your blood, anyways. Okay. Infusions are given oftentimes every 2 to 4 weeks, depending on what the style of your doctor is. Sometimes they give you a whole lot over like 5 days, and then they just give it to you once a month. Sometimes maybe a little bit more in one day, but just given every 2 or 3 weeks. So there are different styles, so I'm not really going to go specifically into how IVIG should be given. We don't really know how it works. Okay? We don't. I mean, we have ideas, and in fact it might work in multiple different ways, and depending on the disease, that the way it works might work for certain diseases more than it works for other diseases. Some people say, well, it's out there. I mean, it's kind of like it's throwing a lot of decoys and confusing the immune system, and that's how you modulate it. So, but this is one of those things where it doesn't actually inhibit the immune system per se, it just kind of modulates it. And in fact, there are patients who are deficient in IG, and we give them IVIG, or nowadays you can also give a sub-Q IG. And it boosts their immune system. And there are a lot of patients who I treat for autoimmune disease, and I give them IVIG, and they say that, I feel like I get sick less now. So it's hard to really call that an immune suppressant. We just now like to call it an immune modulator.
I've read or heard that it's taken from a pool of people.
Yeah.
Is that because there's just too little in just a really small group, or they want to get different types of IgG, or are all the IgGs from everyone the same chemically?
I think that everyone's IGs are different. My IGs are different from yours and different from everyone else. You pull them just by nature. You don't usually get IGs from one particular person, because then there wouldn't be enough IG to
Yeah, I was just curious the reasoning behind it.
Yeah, I think it's a practical thing. Why did you go first?
So do you give IVIG to your treatment, to your patient as like a mean treatment? Because my doctor, he prescribed that only when I'm like in a bad shape really fast, like a quick fix. But he said we're not going to be long term, just for a temporary fix every single time.
What's your diagnosis?
PM.
Yeah. Okay. So IVIG is expensive, so sometimes we do use it as rescue treatment, if that's what you mean. There are situations where we use IVIG on an ongoing basis as well. I think that's what I'm describing here. But yes, a lot of times it may be hard to get insurance to pay for ongoing treatment, so we just give it for rescue treatment. You have a question?
I know nothing is guaranteed. Is it possible we can catch another disease from these donors, like hepatitis or?
Theoretically, yes. I don't think any that's been documented to happen in the last few decades. But yes, I mean, I think when we were giving IVIG in the 80s, that was a problem. People were getting infectious diseases because, the selection process may not have been as rigorous. I think we weren't understanding all the different diseases. And so, certain populations were at risk for developing.
Because I know in the West Coast, in California, I know you guys, some of the blood come from there, or whatever you call it, and they allow people in California to donate even if they're like positive for HIV, like blood and stuff. So.
I don't think that's the case. No, I don't think so. I don't work for any of those companies, but I would be shocked if that were the case, yeah. I think you have to be healthy donors.
Has anyone ever tried a trial of, I think it's tried other diseases, but basically to put a sort of attack on the body with another disease, such that the immune system then switches into high tier fatty fat, and perhaps that may slow down the production of B and T cells for that damaging the muscles. In other words, I don't know how to describe it.
You're talking about
give a patient another disease, which can eventually be treated, but the immune system will then take over fighting that disease and maybe get confused or stop attacking the muscles. Has that been tried at all?
The treatment that gives you a different disease.
That's right. Yeah.
I can. Yes and no. I'm not sure I know what you're talking about. There are certain treatments for cancer, for instance, that can give you autoimmune disease, but that may not be what you're talking about.
No. Yeah, I remember many years ago they were basically by giving the patient a different disease, it sort of reduced the problem of the original disease that they had. But to your knowledge, that hasn't been tried.
Yeah, extreme immunosuppression. We've done that. So, like one of the drugs I'm not going to talk about is cyclophosphamide. And cyclophosphamide is considered one of the most powerful drugs as a chemotherapy drug that we use.
Yeah, but I'm not suggesting suppressing the immune system. I'm suggesting having the immune system attack a different target rather than the muscle cells.
Yeah, I'm not sure which one, but we can talk about that afterwards because we'll have to think a little bit more about what that might be. So it's not really a true immunosuppressant. It might be because these FCs, which is this portion, which is C stands for constant, means every antibody has that same thing. What's different about these different antibodies is the Y part of the antibody, the kind of the gold and the blue that's next to the gold. That's what's different. And they go around binding to different things like, bacteria and other, foreign things. But the portion that's down here at the stem of the Y is constant. That's what FC stands for. C stands for constant. And if you have a lot of FC around, then that might actually tell the immune system to kind of, slow down a little bit. It inhibits the immune system because it means that, you have enough antibodies around. So we think that might be one of the ways, but that's one of the theories. There's also the decoy theory, it's confusing the immune system. The onset is usually within weeks. The disadvantages are it's pretty inconvenient. Got to get an IV. Got to go to a place to have it done, or somebody has to come to your home to have it done. Either way, it's inconvenient. It's very expensive. A whole lot more expensive than any of the drugs I've talked about so far. But nonetheless, sometimes it's the appropriate drug still. Side effects, sometimes the infusion can give you flu-like symptoms, feeling like you have muscle aches or chills. Some patients can have headaches. Some patients can have really bad headaches. And there's rare cases where patients get strained, and they can also get clots from having too much thick stuff in their blood. I have 5 more minutes, so I'll finish up here with the last couple drugs. Rituximab. So rituximab is kind of illustrated right here. It's an antibody. and it's binding to CD20. It's kind of knocking out anything that has CD20 on it. Well, CD20 is actually on B cells, so it kind of takes out the B cells. So it tags the B cells, and the B cells are part of the immune system, so you're kind of just taking them out, and you're almost sort of rebooting the B cell system. So it may be better for certain diseases that are autoantibody, myositis-specific antibodies. Antisynthetase, for instance, is one where we tend to use rituximab a lot because it's been shown to be quite effective. Can be given, one round can be given over 2 infusions or 4 infusions. That, again, is the style of the doctor that you're working with. So the effect usually comes on in a couple of months. Once again, it's one of those things where you have to wait for the other antibodies to kind of clear out of your system, and that's why it doesn't have an immediate effect. The concerns is that you can get certain infections. Sometimes there's this one really bad infection in the brain called PML, progressive multifocal leukoencephalopathy. That's a really bad one. I mean, that's usually death. But that's extremely rare. We can even test for it to see if you might be at risk for it. There's something called a JC virus that we can test. If you don't have JC virus, then you can't get PML. Even if you have it, doesn't mean you'll get PML. I've never seen somebody get rituximab and get PML, but I've heard of it happening somewhere in the country. So it's one of these things where it's extremely rare. But
how long has that been available?
Rituximab?
Yeah.
20 years, probably. Like I said, this is a drug that was originally designed to go after lymphoma cancer. Now we find that it's useful for certain autoimmune diseases.
Is that an immunosuppressant also?
I would consider it an immunosuppressant in a way because you're knocking out the B cells. And it's pretty expensive.
B cells and the T cells have.
It goes after B cells.
Yeah, I know, but it doesn't affect the T cells, but the fact that the B cells disappear or whatever.
Yeah.
You're okay.
Yeah, it doesn't knock out the T cells, but it does affect the B cells. Yeah.
So the risk that the certain infection risk that you mentioned, hepatitis and all that, is it the same level of risk as an immunosuppressant like cell-cell Imuran and all that, or is it like? So
PML, we mentioned this because it's a very serious infection. The other ones, yeah, I would say it's on the same par as the other immunosuppressants. All right, so if you're talking about treatment, let's just talk about how fast these drugs work. So just to review, Prednisone, IVIG, these are fast. They take days to start working. Rituximab, maybe a couple months. Azathioprine, I think if you're optimistic, you can say it's less than 6 months, but really more than 6 months is what we feel like is the clinical benefit we're seeing. Same thing with mycophenolate and methotrexate. Kind of 6 months is really sort of the rule. So if I said, oh, you have myositis, why don't I just start you on mycophenolate? I'll see you back in 6 months. I think you'd be like, that's a bad idea. Okay, all right, because you're gonna, if you have symptoms, if you can't walk, you're going to continue to struggle with that for at least another 4 or 5 months before it starts to slowly kick in, right? So how do we manage medications? Well, we have to think about, how fast the drugs work, what the side effects are, and so forth. And so sometimes what we'll start with are expensive drugs or drugs with significant side effects, but maybe not so bad in the short term. And we use them as a bridge, fast-acting drugs. In the meantime, we also start long-term drugs. You might, for instance, use rituximab, azathioprine, mycophenolate, methotrexate. Sometimes we use more than one of these. I usually try to stick to just one of these, but I don't like to use too many meds at the same time. But if you're really severe, there may be multiple meds that are thrown on you. And then, as this drug, 6 months, maybe up to a year later, as whatever drug I put you on starts to work, I start to wean you off of that drug over on the left, if possible. And the goal, of course, is if you have one of these diseases, we want to get you to close to what you used to be as much as possible. We don't like to see residual symptoms. Now, it happens, okay, but we try to be as aggressive as possible to get the disease under control. Once the disease appears to be under control, then we start to wean, and we may need a long-term maintenance medication, like one of these drugs over here. And so, you know, this is weekly, this is daily, this is every 6 months, but regardless, that would be the maintenance treatment for those. So what is the plan? Well, you know, as you can see, what these plans could be part of whatever your treatment regimen would be, but you know, I tend to favor the bridging to long-term therapy or the induction with maintenance. You know, I don't usually wean people off medications completely unless they have something else on. And I'm not a fan of the start low, go slow. And I think we are out of time, and that's also my last slide. So I thank you for your attention.